Jenna was getting excited there for a minute. Okay, so we do have approximately, not approximately, I think the precise number is 32 people who want to testify today. So what I'm going to do is, we have your, for those who are speaking, we have your testimony in a written document. If you could try to keep it to 2 minutes, I'll ask the revisers to help time that. And then if we do that, that'll put us somewhat over an hour, and then we will hold collective questions till the end, if that works. And instead of reading your summary, or if you provided testimony to us, if you could kind of give us an executive summary of that. We'll give a little bit of grace where we can, but we have a lot of people to get through today, and there is a boatload of written testimony out there in addition to what's going to be presented today. So if those are the ground rules, Megan, are you ready? Timekeepers here. Anyhow, and I don't want to short anybody, but I do want everybody to get through as best we can. So I think the first one I have via WebEx is Tammy Veason, if I pronounce that right, I apologize. Guardian caregiver, and she is on WebEx.
Hi, can everybody hear me?
We can hear you.
Chairman Carpenter, members of the committee, I am Tammy Veason, and I am here on behalf of my brother, Jim Woods. I've been Jim's guardian, caregiver, and advocate full-time since 2015. Jim is the youngest of 4 siblings. He turned 56 years old last year and was born with cerebral palsy, the youngest of 4 the result of his umbilical cord being wrapped around his neck during birth, cutting off oxygen to his brain. Our parents always sought out specialists to advise him on the best path and treatment for Jim's development and future. They wanted the best life for Jim, advocating for him just like I am doing now. Jim loves books, going to church, ball games, going out to eat, trucks, tractors, riding his golf cart, and just being around people. He is so smart, funny, ornery, handsome, and a big flirt. You all have my written testimony, so I'm just going to go ahead and skip to what I'm advocating for here today. I'm advocating for more dentists in our state to accept, care for, and treat the special needs community. Their lives are difficult enough. Why should they have to travel hours away for dental care? We know that this will take an immense amount of work and changes in how our state reimburses dentists, as well as how hospital privileges are granted for those higher risk patients requiring that level of care. Why should this change when they become an adult? Oral health care is so vital to one's overall health, yet it is not easily accessible for my special needs brother. My brother receives great medical care, has access to specialists, treatments, procedures, tests, therapy, whatever his doctor orders. I am baffled and frustrated by all the barriers keeping Jim and others from receiving the so important oral health care they need and deserve. This has been going on for way too long. From everything I've learned, increasing the Medicaid dental rates would go a long way to getting more dentists to provide care for people with disabilities. We need change, and we need it now. I'm hopeful that with the help of Oral Health of Kansas and the many wonderful advocates willing to be a voice and not give up, that we will remove the barriers that so desperately need to be eliminated. Thank you.
Tammy, thank you so much for your testimony. Okay, next, also via WebEx, we have Mary Jones from the Kansas Mental Health Coalition. Mary? Okay, Mary doesn't appear to be on, so we will go down next in order to Dr. Ashley Owen, the National Multiple Sclerosis Society. Dr. Owen, are you on?
Yes, can you hear me?
Yes.
Chair and committee members, as you said, my name is Dr. Ashley Owen. I'm an advocate for the National MS Society, and I have relapsing remitting MS, which is a neurological autoimmune disease that attacks the brain and spinal cord. It's an unpredictable disease that has wreaked havoc on my life. It has no cure, but expensive medical treatments help to manage symptoms. For reference, one visit to my neurologist to receive treatment for my MS cost nearly $80,000. One treatment. Access to health insurance is critical for Kansans, such as myself, to afford medical treatments like this that allow me to live. Since you said you have my testimony, I'll skip a lot of this, but please know that while living with this debilitating condition, I've faced significant barriers to accessing health care that I desperately needed. I've been denied Medicaid, Social Security, disability, and lots of other benefits. Um, due to narrow income restrictions. I've had to completely deplete my retirement savings to support myself, and this denial left me in a precarious situation, unable to afford medications, therapies, and regular medical appointments essential for managing my MS. I referenced the price tag earlier, so imagine how much I had to spend. The lack of insurance coverage had a devastating impact on my life. I missed critical treatments, which led to disease progression and worsening symptoms. I accumulated an overwhelming amount of medical debt, and this pushed me into financial hardship. My health suffered, and my quality of life declined significantly. Years later, I'm still recovering from the setbacks from this Medicaid denial. Medicaid expansion would offer a lifeline to countless Kansans living with disabilities, chronic illnesses, and other health conditions. It would provide access to affordable, high quality health care, ensuring access to essential medications, therapies, and preventive care. Expanded coverage would lead to better disease management, reduced complications, and an improved quality of life. Um, Therefore, I just ask this committee to support Governor Kelly's FY25 proposed budget, which includes resources to expand Medicaid. I implore you to prioritize the health and well-being for all Kansans. Thank you.
Dr. Owen, thank you so much. I don't know if you can hang around for roughly an hour, but there may be questions at the end of all of the oral testimony. So
I'm
with
happy
the,
to answer questions.
okay, thank you. Next I have is Wayne Grau, National Coalition for Assistive Rehabilitation.
I will not be going over this, so I'll make it quick. I'll summarize it as requested. My name is Wayne Grau. I am the Executive Director for the National Coalition of Assistive and Rehab Technology, or NCART for short. We work with manufacturers and suppliers to provide equipment, complex rehab technology equipment, such as specialized wheelchairs, both manual and power, to individuals that need these things. They have very specialized physical issues. Some are injuries, some are disease states. But we work with clinicians, we work with doctors to provide the equipment that is medically necessary and approved by the insurance companies. NCART is not here asking for an expansion of the Medicaid program. We just like to make it more efficient. We have a couple suggestions that I'd like the committee to consider. One is we'd like to ask the committee to consider eliminating prior authorization for complex rehab technology equipment repairs. The problem with CRT repairs is when we provide a chair to an individual, as I said, the physicians involved, the therapist, either an occupational or physical therapist plus an assistive technology provider, they submit the information to the insurance company and they approve it and they say it's medically necessary, we provide it. Unfortunately, the individuals that need this equipment are going to need it for their lifetime. The prior authorization system for repairs takes about 17 days to get a prior authorization. So I'm just going to give you a quick example. I get a call from a consumer and they say, Wayne, my batteries are going down. Can you come check them out? I go out there, I look at them, I say, yes, they're going down. We need to replace them. Next logical question is, Wayne, do you have them on your truck? I sure do. I can't give them to you. By contract, I got to go back to my office. I got to call your doctor, in some cases, get a prescription, and then I've got to submit all this information to the insurance company to wait 17 days to get an approval so I can come back out and give you those same batteries I have right there. It just doesn't make any sense. Again, the insurance companies understand that this equipment was medically necessary. They also know that these folks are going to need repairs. Nationally, 98.2% of prior authorizations are approved. So they are approving a lot of them. It just takes a lot of time. And unfortunately, the folks are waiting for those chairs to be repaired. And sometimes they're not safe. Sometimes they can't be used. So that ends up with potential problems as well. Number two, we are asking the committee to consider covering the cost of travel time and repair assessment time. We provide services within the patient's home 82% of the time. A lot of these folks don't have van accessible, wheelchair accessible vehicles to come to our facility. So we go to them. And our service areas are typically about 100 miles. So we go out there, we fix these items, we go to their home, we have to make adjustments because people change. So if a person gains weight, we expand the chair a little bit. If they lose weight, we bring it in. All this is typically done in the consumer's home because they can't come to us. So everything is covered excluding the coverage for travel and for the repair assessment. So all that mileage I just talked about is not covered at all. Either is the repair assessment time, which I've repaired chairs. I'm not great at it, but I've done it. And it could take anywhere from 15 minutes up to an hour. So all we're asking is we don't want to be forced to condense our service areas. We want to be able to maintain those. You know, Kansas has got a lot of folks that live in small towns and rural areas. And we want to make sure that we're able to service them just as well as we do people in the larger cities. The third thing is we would ask that you would consider authorizing and allowing preventative maintenance. We are not allowed to fix a chair until it's broken. That makes no sense. We do preventative maintenance for automobiles. We do preventative maintenance for farm equipment, for machinery, everything. What we want to do is we want to identify problems and fix them before they become emergencies. Because again, if a chair goes down and we call it a hard down, where it just stops operating, that consumer could be stuck. And we just want to be able to fix it if we see it beforehand and get that done so that consumer is not in that position. I'm sorry I kind of ran through this pretty quickly, but I wanted to respect your time. I appreciate it, and if I can answer any questions, I'll be more than happy to, but thank you very much.
Thank you. I think we'll move next to Rochelle Colombo. Rochelle, welcome to committee.
Thank you, Mr. Chairman, members of the committee. I am Rochelle Colombo. I'm the Executive Director of the Kansas Medical Society. We represent physicians statewide of every specialty. And I'm here today for 3 reasons, and I'll be very, very brief. The first is to thank you. Prior to 2006, the Medicaid physician fee schedule had not been adjusted. For that entire period since 2006 until 2023 and 2024. And the legislature passed first a 3% increase across the board, and then last year, a 9% across the board increase to the physician fee schedule for Medicaid. Unfortunately, we learned after the legislature adjourned that 9% across the board increase was not applied as allocated. There was a response back from KDHE about a rule relating to the Medicare fee schedule and that it had to be adjusted. However, we know that was not the legislature's intent and that we spent a lot of time working with you all to make sure that we have an adequate network of physicians that can continue to provide care for the 425,000 Kansans that are a part of Medicaid. So my first was thank you. My second is a report back that although you all did heavy lifting on that and appropriated, I think, just a bit more than $10 million to make that increase, it didn't actually apply across all codes. Some codes were increased, some were left, and I don't think any were brought down. But there are a number of codes that were not affected that are relevant for the Medicaid community. So my third is a very simple request. I know you have a lot of testimony. It's on page 3 of what I submitted to you all, which is very simply to ask and to work with KDHE to develop a separate fee schedule for the MCO contracts as it relates to Medicaid so that those can be appropriately compensated to maintain the physician network. And we would simply ask that you all would direct KDHE to work with you in establishing that. And then we'll come to you in a future date to talk about how we can incrementally work on adjusting the fee schedule to keep up with the necessary cost of providing that care. That's my testimony. I really appreciate the opportunity. And again, thank you for your hard work on this issue.
Said, short and succinct. Thank you so much, Rochelle. Yes.
Mr. Chairman, maybe this might interrupt your schedule a little bit, but here's what I have from KDHE. Here's the methodology for physicians' fee increase. This is codes currently 91% of Medicare increased to 100% of Medicare. 9% increase in all codes, 91% of Medicare. Codes of no Medicare equivalent were increased by 9%. Code 65% of Medicare after the 9% increase, no increase above the 9%. With additional funding, select codes under 65% of Medicare with high utilization, additional increase up to 65% of Medicare. That's what I have. If there's something different than that, I'd like to know about it.
I do believe that's correct. That is, I think you explained it exactly right. It is very different than what the legislature passed and appropriated. And again, we would like to see a separate Medicaid physician fee schedule that is not based off of Medicare, because physicians are not required to take all Medicaid patients. They're different than hospitals. They participate because they want to take care of the patients in their communities, but Medicare is not covering those costs. Those have been cut at the federal level. It's a problem if we're going to base our physician fee schedule off of Medicare, which will not cover costs, and it will deteriorate the network. So that is why our request is to create a separate fee schedule for the MCOs that are contracting with the state.
Very good. Thank you.
Thank you.
Sorry, Mr. Chairman.
No, thank you, Representative Carpenter, and thank you, Rochelle. Okay, let's move on to Ryan Morgan from Special Anesthesia Services. Ryan?
Mr. Chair and committee,
Welcome
thanks
to
for
committee.
having me here.
You're welcome.
As you mentioned, I'm Ryan Morgan with Special Anesthesia Services and at Astra Anesthesia. We've been doing office-based anesthesia for the dental community for about 25 years. We do recently 3,700 cases over the last year, which 75% are our Kansas MCOs are covered by. We partnership with organizations like Grace Med and Parsons State Hospital to care for these special needs clients. But find it difficult with regards to reimbursement, similar to our previous speaker, Medicaid and Medicare. Oftentimes with those special needs patients, we might pull $150 out of a 2-hour case, and the supplies cost that. So that's where the network deterioration is coming from. So those are basically pro bono cases for us. So we supply the service out in the community, the dental community, because it's difficult for them dentists to get credentialing at hospitals. They don't really put dentists in a priority because of reimbursement and then increased equipment costs, lack of OR time. The special needs patients have more apprehension in a hospital. They do better in an environment where they've been, relationships have been fostered, nurtured with the dentist over months to years. And so we meet them there and get them taken care of there. Their day's shorter. They're not there all day. Over the last year, just in facility fees alone, we've estimated that special anesthesia services have saved the Kansas taxpayers around $5 million. Just by not having facility fee codes for the setting that we're in. We really lose it, as I mentioned, on Medicare, Medicaid, duals. That's the biggest struggle. Recently, our lobbyists have had good discussions with KDHA, and as a result, they feel like they have a good understanding of what our value is to the Kansas Medicaid, Medicare clients and the Kansas taxpayer. So we asked for you to add funding to KDHD. And while we work with them, we're still in the process of working with them to figure out what would be a mutually beneficial position moving forward. Yeah, that's all I have.
Thank you so much.
Thank you.
Okay, next up is Kevin Robertson, Kansas Dental Association. I think I saw Kevin somewhere. Kevin, welcome to committee.
Mr. Chairman, members of the committee, I'm Kevin Robertson, Executive Director of the Kansas Dental Association. KDA has 3 requests for you today, of which I know at least 2 of those requests are going to be covered quite extensively later on by Oral Health Kansas and some other groups. But just to let you know, we are asking for a $16.9 million increase in SGF for dental Medicaid to get us up to a funding level that's equal to Missouri. And an experiment that they did, they've drastically increase the number of providers in that state. And so we're looking for the same sort of funding here in the state of Kansas. Also looking for an increase in 1.3 million SGF so that we can increase the 0330 code that has to do with anesthesia that was just being discussed, so that those special needs patients can be seen in hospitals. That's the reimbursement rate for those hospitals, so that they would be more incentivized to allow dentists into their facilities to provide treatment. And then lastly, Also on page, I guess it'll be on page 2, 1 and 2, we're looking for an increase in funding for what we call the donated dental services program. For the last 10, 12 years, the state has allocated $70,000 to that program. Actual program costs were $125,000. So we would ask for that increase of $55,000 for that program. Donated Dental Services Program is a program that dentists volunteer to provide treatment to frail, elderly, disabled folks. And the costs involved in that program pay for a program coordinator and some lab fees associated with those treatments. So that's would be my request and my today. That'll be it.
Kevin, thank you so much.
Thank you, Chairman.
Okay, next up, another familiar face, Jamie Gideon from the Alzheimer's Association. Welcome to committee.
Thank you, Mr. Chair and members of the committee. My name is Jamie Gideon. I'm the Kansas Director of Public Policy with the Alzheimer's Association. And here at the Alzheimer's Association, we're concerned about Kansas residents that are under the age of 65 who are on Medicaid and experiencing cognitive impairment. CMS, a few years ago, created a billing code called CPT 99483 to reimburse providers who provide cognitive assessment and care planning services. Medicare covers this nationwide, but it is an elective service on state Medicaid plans. Care planning can save on state Medicaid costs, which are currently $473 million in Medicaid dollars just spent on Alzheimer's in Kansas each year. By reducing the number of hospitalizations, by proactively addressing safety risks at home, managing medications, proper nutrition, and utilizing community support services. Those with Alzheimer's have 2 times the increased risk for hospitalization. In fact, once 13 people out of the 435 people that we show are eligible for this use this code, the cost would result in a net increase in Medicaid savings. I said a net increase in Medicaid savings. Every time the code is used by a physician, the state would see a minimum $3,000 increase of reduction in hospitalizations per person. Therefore, we request $32,000 SGF to begin the process of activating the billing code and reimburse providers for cognitive assessment and care planning. Thank you.
Jamie, thank you for that. Vice Chair was not trying to distract you, but he has been a little under the weather, so.
Yeah, and I apologize for this.
Yeah, he's a trooper. Okay. Okay, let's move on to have Chad Russell, the fire chief from Andover. Chief, welcome to committee.
Oh, thank you so much. There will be no coughing during my talk. Touche, sir. Thank you so much for the opportunity. I'm not only the fire chief in Andover, but I'm also the president of the Kansas State Association of Fire Chiefs. So thank you so much for letting me be here. I'm really good at 40 minutes, so I'm going to read some notes so I don't do that to you. Today, I'm appearing not only on behalf of the KSAFC, but also in our written testimony, you will see a ton of logos. We have fire departments, we have International Association of Firefighters, we have Kansas EMS Association, we have sheriffs, chiefs of police, etc., all coming to you for an ask today. Our first responder groups aren't typically here at budget committee meetings, so you know this has to be a big deal for us. What I'm here to talk about is home oxygen therapy, and we have a bunch of Kansans that are on home oxygen, and just a little bit about that. These people have emphysema, they have lung injuries from work, they have lung injuries from the military service, etc. This oxygen at home is a life-saving device, obviously. However, since 2018, there have been multiple fatality fires caused by an ignition source around home oxygen therapy users, and many, many injuries. A couple of the headlines: woman dies in house fire in Delano District on home oxygen. A man dies in house fire in Wichita on home oxygen. 2 killed in early morning house fire in Kansas City, home oxygen involved. There's all kinds of headlines that I can go through, and it's extremely impactful, obviously, to the family involved. It's also impactful to your firefighters. We have firefighters that are injured in these fires as well. It's a really big deal for us. The cool thing is there is a solution. So there is a device called an oxygen fire break. It goes in the oxygen circuit in the tubing, and when there is an ignition and the oxygen catches fire, or the tubing catches on fire with the oxygen fire break stops the flow of oxygen immediately. So we can't stop the ignition of the fire, but we can certainly save lives and decrease fire damage. So how big of a deal is it? We're still working on getting the exact data for you. We included some data in our written testimony, but just Via Christi St. Francis since 2018 spent about $2.9 million in treating home oxygen therapy burn patients. That's just one of our burn centers. These fire breaks cost $4 per device. I know because I bought a case of them so I could carry them around and show them to folks like you. Iowa, North Dakota, and Washington have included them in their Medicare reimbursement. Iowa and North Dakota are doing it for a few dollars over what it costs me to do. And on the behalf of Kansas responders, we would ask you to provide an appropriation of $40,000 for Medicaid coverage for the oxygen fire breaks to protect the most vulnerable in our communities, preventing fires, saving lives, and ultimately taking a load off not only our already strapped fire departments, but the already strapped state Medicaid system as well. Thank you so much. I would very much look forward to having an opportunity to talk about some questions.
Chief, thank you so much for being here. I think you scared the coffin out.
Yes. That's my paramedicine at work. You're welcome, sir.
Just a quick, are those called cannula valves?
Yeah, they're supreme or premium cannula valves.
Okay.
Yes.
Thank you.
Yeah. Some people didn't get that, sir.
Right. Okay, so we're going to back up. We had missed Mary Jones from the Kansas Mental Health Coalition. She was the second conferee via WebEx. I think Mary is available with us. So, Mary, welcome to committee.
Speak to you today. I'm president of the Kansas Mental Health Coalition and also president of and CEO of Mental Health America in South Central Kansas, located in Wichita. We request that the committee, we're recommending an increase to the protected income limit for the medically needy program and support funds for private psychiatric hospitals as requested by the Kansas Hospital Association. My organization is a provider of mental health services in Kansas, and the current income limits for eligibility, while intended to ensure that resources are used effectively, often don't reflect the true cost of living. And we know that the income limits are preventing many individuals from accessing the care they need to lead healthy, stable lives. We see the importance of the medically needy program for people with mental illness to continue lifeline supportive services such as psychiatric care and medication management, therapy and counseling, crisis intervention services, and case management with other community-based supports. There is no waiver for adults with mental illness, so many of these services, many of these individuals access care through this program for the medically needy. Here are some reasons why we think that this issue is so important. One is it supports recovery and stability. So we know that many of the people that experience mental illness often face barriers with cognition or emotional instability and are unable to sustain long-term employment. Raising the protected income limits for these folks will allow them to ensure that they continue to get the care and support they need. We also know that it can reduce hospitalization and emergency care. When individuals with mental illness lose coverage, they often forgo regular routine treatment, and that can result in higher end and more acute needs later on by way of emergency care and hospitalization. We also know that it's important to improve access to housing and employment. Medicaid provides not only medical care, but also critical case management that help individuals not only access stable housing, but maintain stable housing. By raising the protected Medicaid income without jeopardizing their health care, they can improve their quality of life and reduce reliance on other state-funded programs. And It'll also alleviate the financial strain on providers. Mental health providers like us work to help people remain in the community and avoid costly and sometimes traumatic institutional care. It is a challenge to cover the cost of that care for people who are on and off the program. Under the current model, their eligibility fluctuates every 6 months, and this can result in longer wait times, reduced services, and increased financial strain on providers. Regarding hospital funding, please recall that Amy Campbell did testify to this committee regarding the state mental health hospitals and communicated our support for effective continuum of care. Supporting the community hospitals that operate psychiatric units assures that we not only rely on state institutions for the care of Kansas who need psychiatric hospitalization. This funding has been provided through KDHE and needs to be renewed. Thank you so much for the opportunity to speak today. Please feel free to contact me if you have any questions.
Okay, Mary, thank you for your testimony, and thanks for getting back in the queue today. Thank you so much.
Thank you.
Okay, we're going to move on, and Francie, I want to check. I have, after the fire chief, had John Cuff, C-U-F-F-E. Am I pronouncing it correctly? You are. I should play the lottery. John from the Cerebral Palsy Research Foundation.
Thank you, Chairman, Vice Chair. Thank you for allowing me to testify on behalf of Cerebral Palsy Research Foundation of Kansas. We are located in Wichita, Kansas, and our posture seating program. We're also speaking on behalf of our clients across the state. I'm an occupational therapist with 12 plus years experience of healthcare. We operate the largest customized wheelchair seating clinic in the state of Kansas, serving individuals statewide from liberal to independents and all areas in between. As the only Medicaid-approved wheelchair seating clinic outside the Kansas City area, our mission is to support individuals with physical and intellectual disabilities by providing essential wheelchairs and equipment and advocating for their needs. A little background about CPRF. We've been fitting individuals in wheelchairs since the 70s. Posture seating is critical for those children and adults with severe disabilities who utilize wheelchairs. The primary purpose is to facilitate their mobility, keep them comfortable, and also prevent secondary medical conditions, pressure ulcers, and other hospitalizations. Some of the challenges. Over the past year, I've encountered significant challenges due to a large amount of denials from our Medicaid providers, MCOs. This puts our clients' health at risk, leaves them stranded, as their wheelchair is their only means of mobility. These hurdles increase the time our therapists spend writing letters of medical necessity, involve multiple back and forth interactions with vendors and MCOs, and justify the medical necessity of this equipment. This results in prolonged wait times for the clients that we serve. In my past year, I've seen custom molded seats that have been denied. I've seen a client that used eye gaze to direct their chair being denied, and now they're confined to a manual wheelchair. A client with muscular dystrophy was denied a power chair, and a client that had with cerebral palsy that asked for anterior tilt on a chair to prevent choking and aspiration was denied. We served 843 unduplicated clients last year. The demand for our services continues to grow in Kansas, and as a nonprofit, we provide wheelchair fittings with the same level of expertise. At CPRF, we advocate for our clients' medical needs, and we act as a watchdog for the vendors. We ensure the clients get what they need and what's medically necessary. Overall, timeliness and efficiency. The best case, if all goes well, a wheelchair will take 3 months for clients to receive that wheelchair and the parts needed. Our therapists are spending 30 minutes up to 2 hours researching and writing letters of medical necessity just to justify medically necessary equipment. These repeated denials and delays by the MCOs cause the undue stress on our clients and hardship. I have more in the letter, but I appreciate your time.
John, thank you so much. Appreciate it. Okay, I'm going to move down to Dawn Manier, also from the Cerebral Palsy Research Foundation. Dawn?
Chairman and committee members, I am Dawn Manier, and I'm here today with my husband, Brad, and our daughter, Haley. It's now been 32 years since Haley began using a wheelchair. She was initially fitted for a wheelchair at the age of 3 years old at CPRF's Wheelchair and Posture Seating Clinic. A properly designed wheelchair and seating system has been critical for Haley to maintain her independence, from her past school days to her current work requirements, and daily activities. Haley has cerebral palsy and is unable to walk. Therefore, she spends nearly all day in her wheelchair. Scoliosis and kyphosis cause her back to be out of alignment. So in order to sit comfortably and prevent pressure sores and skin breakdown, she requires a custom-made backrest and seat. We are very fortunate to have a seating system built by CPRF, and it has eliminated any of those secondary health-related issues. CPRF has also built customized trays that fit Haley's chair. She can use the tray as a desk for her computer or her books, and also as a table for food. These types of adaptations are essential requirements that unfortunately can be easily overlooked if you consider a wheelchair as a tool for mobility only. Haley's needs, as well as the needs of many like her, cannot be met by going to your pharmacy and purchasing a standard wheelchair. Finally, one of the great advantages of the CPRF posture seating program is that they maintain a large inventory of spare parts, and we have often gone to the clinic for emergency repairs. They will find or build the part there on site to help get you by until a new one can be ordered and delivered. And if necessary, they can provide a loaner chair. As Haley has become an adult, it seems that resources have become less available while the needs continue to grow. In addition, CPRF's client base typically has very limited financial resources. Because of this, the generous support of this committee continues to be vitally important to ongoing efforts at the Wheelchair and Posture Seating Clinic to meet the needs of some of the most vulnerable individuals in Kansas. Thank you for your past support and for the opportunity to be here with you today.
Dawn, thank you so much for your testimony. I do have Haley Manier on the conferee list. Get Haley up here. Haley, welcome to committee.
Thank you. My name is Haley Manier. I would like to thank you for your support of the CPRF Wheelchair and Posture Seating Clinic. I am not only a long-term client of CPRF, but also an employee. I work with the case management department doing data entry with their single point of entry program. My wheelchair provides me a sense of independence and allows me to do my work activities and move freely throughout the day. Before my wheelchair, I was dependent on having someone else take me where I needed to go. As an adult who is now in her 30s, it is not only vital to have a wheelchair for my work at employment opportunities, but also for important social activities like church and other functions with family members and friends. I also have a manual wheelchair that was custom fitted by CPRF, and that can be folded in place in the car for easy storage. I use this chair when I go to other family members and friends' houses that may not be wheelchair accessible, as well as when I am out of town. I want you to know how much I appreciate your support of a program that is vital in helping me and others in my situation to maintain our independence. Thank you.
Haley, thank you for your testimony. Very much appreciate that from your perspective. So we also have one more conferee from the Cerebral Palsy Research Foundation, Pat Jonas. Pat, welcome.
Thank you, Mr. Chair and Vice Chair Carpenter and committee. Promise this will be the last time you'll see my face this session, hopefully. Appreciate your time last Friday. I'm president of Cerebral Palsy Research Foundation, and I have two requests, if possible. First and foremost, like the NCART gentleman was stating, it's one thing to need a battery or a part, it's another thing to need an entire wheelchair. And we, as John had mentioned, we have excessive denials from the MCOs, and there's 4 certified Medicaid seating clinics in the state of Kansas. One's Children's Mercy Hospital in Kansas City, Missouri, and one is KU Med Center up here, and the other is a relatively new one in Olathe, and then CPRF, which is in Wichita, and we serve almost the entire 2/3 of the state. We have outreach clinics, as John mentioned, Garden City and Liberal, Hayes, Salina, Independence. We're kind of all over the place. And 2 issues come up is when our therapists, instead of seeing clients, we saw over 800 last year, they're writing letters of medical necessity versus actually doing evaluations. Now, these clinics require very specific, that you have to have a credential from an accrediting body, which we do from CMS, and then you have to have specific team members. You have to have at least 2 years experience as an OT or a PT or a doc or an RN. You have to have 2 years of experience working as an ATP with a durable medical equipment company, and then 1 year as a technician. So there's only 4 of us out there. And like the person who provided testimony from NCART, we would greatly appreciate the opportunity not to have a pre-authorization for wheelchairs and parts when we are the experts in the field. I mean, we send these off, they send them back. It's an average, you talked about 19 days for a battery. It's 147 days for a wheelchair from day that the evaluation occurs to delivery. The same DME company that we work with in Oklahoma, it's 104 days. It's 92 days in Missouri. It's gotten silly, and I don't know why the MCOs are telling us we don't know our business or they know it better than we do, because like the gentleman was saying, the majority of these get approved. It just takes forever to get it happening. So the first ask is that the wheelchair clinics, of which there's 4, would not require pre-authorization for this equipment, but it would have to be a referral that is written or an evaluation that's done by one of the medical professionals on the team with no attachment whatsoever to the DME. They can't be a contractor or anything. We are the middle person between the durable medical equipment company and the client. We are the advocate for the client, so I don't think there should be an association there if you're not going to have a pre-authorization. Secondarily, funding, if at all possible. We haven't asked for funding in about, it's been over 5 years. We have a $1.3 million cost center budget. About 28% is funded through the state. We go find the dollars elsewhere. We have a $388,000 deficit coming up this year. We can annually fundraise about $125,000, but that's been pretty much our plateau. And so we would be asking for SGF funding of an additional $263,000 in addition to the prior authorization request. And thank you very much, Mr. Chairman.
Appreciate it. Okay, let's move on. The next conferee we have is via WebEx, Melanie Jacobs, parent, guardian. Melanie, are you with us? Melanie, can you hear us? She is online and not responding.
Can you hear me?
We can hear you now.
Okay, thank you. Chair Bueller and committee members, my name is Melanie Jacobs, parent guardian to my daughter Sandra. I feel compelled to further emphasize the urgent need for action regarding dental care in Kansas. I am providing testimony on the critical issue of access to dental care for adults with intellectual and developmental disabilities, IDD. As someone who previously provided oral testimony during the Special Committee on Sedation Dentistry chaired by Representative Carpenter, I respectfully request that this committee review the recommendations made by that committee. These recommendations represent thoughtful solutions to address the barriers dentists faced and improve access to care for the most vulnerable population. This included reviewing other states' rates while planning to increase the Kansas reimbursement rates to be in line to attract more dentists. Taking these recommendations into account and implementing them will make a meaningful difference for adults with IDD who rely on Medicaid for their dental services. As a parent of a child with quadriplegic cerebral palsy and other complex medical needs, it is incredibly challenging to find adult dentists. After 41 phone calls in one day, all listed in the Medicaid handbook, they were either not accepting new Medicaid patients, did not do office sedation, and not one did hospital care. We now drive an hour and a half away so my daughter can have the care that she needs. Access to dental care is not a luxury. It is a fundamental aspect of health and well-being that we must ensure is available to everyone, regardless of their abilities. I urge the committee to consider these concerns in your discussions and decision-making process, especially related to increasing the Medicaid dental rates in order for more dentists to provide care for people with disabilities. Thank you for your attention and commitment to improving services and supports for Kansas with IDD. Thank you.
Melanie, thank you for your testimony. Okay,
Thank
next
you.
up, you're welcome. Next up is Randy Bowman, Kansas Association of the Local Health Departments. Randy, welcome to committee.
Mr. Chairman, members of the committee, thank you for the opportunity. My name is Randy Bowman. I'm the Executive Director of the Kansas Association of Local Health Departments, which represents your health department in your community. 5 items before you there. I'm going to hit them really lightly. So continue the proviso that moves the funding from statutory $7,000 to $12,000. I do see that language in the budget bill. Let's just, again, this year, make sure we don't lose it anywhere, please. Staffing for local public health program, that is item number 5 on page 8 of your document from yesterday. Those are vital connections to help coordination between local health departments and the state health department. So I really ask for your support to sustain those positions. Funding for the sustaining the laboratory courier services. Thankfully, after a lot of advocacy in the summer, fall, and with some of you, the Kansas Department of Health and Environment has told me they have found a way to fund this. So please, let's not have the other decisions we make mess that up for them, would be my message today. We have to keep that access for 105 counties to this shiny new laboratory, not just those of us who might live here in Shawnee County. Mr. Dennis Kriesel will be up somewhere on your agenda, and we'll speak more about this, but Johnson County has some specific proposals from their health department that the association also will support. And then you are hearing from many folks on dentistry, and we just will make sure that we have our voice in that conversation as well, because it is the infections that can come from lack of dental care really do also affect chronic pain, disease, and other health care issues. So this is a preventive strategy to avoid other costs in the Medicaid program if we would just pay dentists a fair market rate for their services, and hopefully more would provide services to our citizens. And with that, I would stand for questions at the appropriate time or take questions another day from folks.
That was excellent. I think you're setting the standard there.
Okay.
Out of there, or well done.
Good deal.
Thank you so much.
Thank you.
Okay, next up via WebEx, Dennis Kriesel, Johnson County Department of Health and Environment. Dennis, are you with us?
I am. Can you hear me?
We can. Thank you.
Excellent. Well, thank you for having me. Dennis Kriesel, Deputy Director for the Johnson County Department of Health and Environment. I don't want Randy to outdo me, so I'll try and be even more efficient with my time. My details are, of course, in my written testimony, but we have 3 enhancements we'd like to request the committee consider. The first would be $1.58 million to establish an uncompensated care program for local health departments. And I have the details in the testimony, but basically, you have a model for this already that FQHCs use called the Community-Based Primary Care Clinic Program, but we don't participate in that. We would like to have a program that's very similar for local health departments to be able to access for our write-offs on the 200% and below federal poverty level sliding scale. Request number 2, tuberculosis. You've probably been hearing about it a lot lately. There's been a lot of national media attention. We'd like to ask you to consider adding $96,000 to support tuberculosis control efforts. Currently, my understanding is KDHE receives approximately $54,000 for that. And the way that's done is $49,500 goes to locals for what we call indigent care grants to be able to cover things like utilities for those that are undergoing TB treatment and cannot work because they are still contagious. And then the other $4,500 is kept by KDHE to cover lab supplies and the purchase of medications statewide. This move with this enhancement would move that $49,500 indigent amount. We'd like to see that go to $110,000 and make that $4,500 that KDHE is using and move that to $40,000. So it would move all of this up to being a $150,000 investment in controlling tuberculosis. And the third and final item would be $100,000 for the state formula grants that are governed under 65-242. This committee has been a tremendous supporter of getting that caught up for us, and I very much thank you for that. This would just reflect the $100,000 is the inflation that we've seen over 2024 calendar year. And with all that, I'll stand for questions at the appropriate time. Thank you.
Dennis, thank you. That was right on the mark. Thank you. Okay, next I have up Aaron Dunkel, Vice President and Regulatory and External Affairs for the Community Care Network of Kansas. Aaron, are you? Oh, there he is. Welcome.
I'll get here quick. I'll try to match Randy and Dennis. Thank you very much, Mr. Chairman and committee, for time to testify in front of you today. Really, we just want to say three quick things. Number one, thank you for your continued support from the legislature for primary care, specifically for our 25 health centers that are providing care at 90 centers across the state. Real quick, for those of you who don't know, and we'll come around and visit a lot more extensively as session goes on, we're open to anyone, mostly on sliding scale. 84% of the patients we see make under 200% of the federal poverty level. And what your investment has helped support over the years, at this point, we see about 1 in 9 Kansans in one of our centers across the state. So about 350,000 folks come through our doors, representing about 1.2 million unique visits. We provide medical, dental, pharmacy, behavioral health, substance use disorder, care management, wraparound services such as transportation and nutrition. And to give you an idea what that leverage is, last year we had about $57 million worth of uncompensated and free and reduced care. The one ask we would have at this point, and then I'll be done, is really to help support the increase to dental rates within the Medicaid program. We have a vast majority of our centers do provide dental services, and I'll tell you from being out and talking to our folks, it's one of the places where they have it's one of the more difficult places as far as the funding of it, and when it comes to workforce recruitment and retention, it's our number one request of our workforce recruitment staff is to help them find dentists and other dental professionals. And with that, I'll stand for questions when appropriate.
Aaron, thank you so much. Appreciate it. Trying not to lose my place in my notes here. So next up is Mike Burgess, Disability Rights Center of Kansas. Here's Mike.
Sorry, I wasn't as fleet of feet as Aaron was. So I'm Mike Burgess with the Disability Rights Center of Kansas, and I appreciate the opportunity to highlight one issue before you. There's lots of important things, as you've been hearing, and so appreciate all of your diligent work and all the work that goes into making this happen and putting together the budget. I also want to say thank you in the past for those of you that were here back when we advocated to raise the protected income level for the HCBS waivers and PACE program. That has been a game changer. I mean, that was so important. Deputy Secretary Osterland has talked about a different program that actually has an even lower income level, and that's as a previous conferee talked about, the medically needy program. And so that has been locked since 1996 at $475. And Deputy Director Osterland had some slides at a previous KinCare or Bob Bethel meeting, KinCare Oversight meeting, that provide some great input, and she is much, much better at explaining this than I ever could hope to be. So I'd be happy to send the link to everybody with that so you can find and look at those slides. But essentially, they have to have medical needs that bring their income down to $475 to qualify for this program. And it's just hard to live on $475. I mean, we're making it unnecessarily difficult. So what the ask is to raise that to spend $940,000 SGF to bring that just up to SSI, 100% of SSI, which is still significantly less than the waiver programs. But that would be we would love to go higher than that, but just asking for to make it significantly better for those folks. SSI for 2025 is $967 a month. So that's still, they're not going to be living the high life by any means, but it's certainly going to be a lot easier for them to eke out a life while participating in the program. So thank you very much, and I'd be happy to stand for questions at the appropriate time.
Thank you, Mike. Appreciate that. Okay. Next up is Sarah Peltzman, Advanced Specialty Anesthesia. Sarah, are you with us?
I'm here. Can you hear me?
We can. Welcome to committee.
Hi, I'm here to present the testimony for the owner of Advanced Specialty Anesthesia, Jeff Glasgow. We're a mobile anesthesia company that travels the entire state of Kansas, and we provide office-based sedation to dental offices. We're currently collaborating with KDHE regarding a coding problem with the CMS in regards to Medicare primary, Medicaid secondary patients, also known as your DSNPs, your special needs population. And the issue is when patients have the Medicare primary, Medicaid secondary, our services are only paid at the Medicare allowable, which is around $200 usually. The reimbursement just isn't adequate to cover our unique costs and our unique business model. So we are offering a better patient resource and solution that saves money for everyone by keeping the care in the office, in these dental offices. And our solution is to allocate with KDHE a coding system that pays the equal amount to hospital or ASC to the mobile anesthesia group. Simply mobile anesthesia groups have the same expense and liability as the hospital or ASCs, and there should not be a discrimination there. And so we are hoping to have a resolution to this issue so we can get benefits going in 2026 for these patients. That's all. Thank you.
Sarah, thank you so much for your testimony. We're going to move on now. Heather Braum from Kansas Action for Children. I see Heather out there. Heather, welcome to committee.
Thank you, Mr. Chairman. I am Heather Braum, Senior Policy Advisor with Kansas Action for Children, and I wanted to highlight 3 of the priorities you find in our written testimony. First, we ask that you continue supporting the budget proviso related to the Children's Health Insurance Program. I see Representative Carpenter smile. It's already in House Bill 2007, and this is language that has appeared in the past 4 budget bills. This proviso temporarily continues to address a 17-year and counting issue with existing state law that ties the CHIP eligibility percentage to the 2008 federal poverty level. For 1 year at a time, the legislature has passed this proviso that keeps CHIP eligibility at 250% of the current federal poverty level instead of back in 2008. We continue to seek a permanent fix to this issue, but until that happens, we need you all to keep that budget proviso in the budget. Second, we support 2 additional budget provisos. One you've already heard about from the Local Health Departments Association regarding the local health department funding formula, and that is in the budget bill. And then also the newborn screening budget cap proviso that is also in House Bill 2007. That is a critical program that screens every infant for a number of diseases that when treated early can change the trajectory of young children's lives. Finally, we support the CanCare reimbursement rate increases requested by the Oral Health Kansas and for dental providers and by the Kansas chapter of the American Academy of Pediatrics for child sick visits. Reimbursement rate increases have been shown to increase providers taking CanCare, an important source of insurance coverage for thousands of low-income Kansas children. Thank you for the opportunity to speak, and I'll stand for questions at the appropriate time.
Heather, thank you so much. Okay, next up is Jennifer Goring, Vice President, Nursing and Operations, Ascension Via Christi St. Joe. Jennifer, welcome to committee.
Obviously, I'm much shorter than everyone else. Good afternoon, and thank you for having me again. My name is Jennifer Goring. I'm the Chief Nursing Officer at Ascension Via Christi Hospital, St. Joseph in Wichita. Ascension Via Christi is a not-for-profit organization, and our mission serves as a big part of serving all, and especially those who are vulnerable and underserved. So as we look forward in our fiscal year 24, we provided $62 million in community benefit for the those people living in poverty. First, I want to say thank you for your partnership last year. After the hearing, the legislature appropriated $10 million to supplemental funding to support and maintain private inpatient behavioral health throughout Kansas. I'm here to ask for this supplemental funding to be continued and to increase in the amount of $15 million. This will also allow our rural health hospitals to keep open their geriatric beds that are serving our geriatric behavioral health patients. So the annual supplemental funding is critically important, not only for addressing the shortage of behavioral health inpatient beds, but also maintaining the current number of beds we have currently. This shortage is a serious issue that is having a ripple effect across the healthcare systems in Kansas. Every month we see at Ascension Via Christi St. Joseph hundreds of behavioral health patients from across 70 counties. We account for nearly 30% of public inpatient behavioral health beds across Kansas, outside the state hospital system. In each of the past fiscal years, we have had a financial loss averaging from $3.5 to $6.2 million for behavioral health services. Because of this loss, these losses are unsustainable. The funding support that the legislature provided last year has been helpful to mitigate the financial loss with this service line. It absolutely allows us to maintain the 101 behavioral health beds we currently have at the St. Joseph Hospital. Every month in our 29-bed ED, we see about more than 500 behavioral health patients, and this creates significant challenges for patients, staff, and our healthcare. In this environment, can be very volatile, which our team experiences about 1.5 average staff assaults daily, making it very hard to retain staff and to hire staff in. This helps address the environment. We are very grateful for last year the support of the governor and the legislature awarding us $22 million through SPARK process, allowing us to have much needed enhancements within our ER. We are increasing our beds by 20 and also adding an additional 11 bed observation units. All of this is for behavioral health patients. And this is set to be completed mid-2026. Via Christi serves the poor and vulnerable Kansas, and this increases our patients covered by CanCare and uninsured. While my testimony is focused on the supplemental funding, we also are here to echo KHA support for the state's continued investment in Medicaid reimbursement rates. We appreciate the increase in the physician and hospital Medicaid base rates approved last year. We hope you will be favorable in considering the request for the additional increase to our Medicaid base rates. In closing, I respectfully request the committee to approve the important funding measures. Thank you.
Jennifer, thank you so much. Okay, moving on. Next, we have Dr. Tasha Van, Public Policy Committee Member, Kansas City Chapter, American Academy of Pediatrics. Doctor, welcome.
Good afternoon. Thank you, Chairman and members of the committee. My name is Tasha Van. I am a pediatrician in the Kansas City metro area, and I am here representing the Kansas chapter of the American Academy of Pediatrics. I'm mainly here to share my story. Our mission is simple: to ensure that every child has access to quality pediatric health care. However, I want to highlight the challenges that we are experiencing due to low Medicaid reimbursement rates. Late last year, I had to make the difficult decision to stop accepting Medicaid patients age 5 and up. And that was a really hard decision for me to make. I became a pediatrician because I want to care for children. I want to care for all children. And when I separated from the Air Force and was looking for a private practice to join, finding a practice that accepted Medicaid was very important to me. But currently, my patient panel is about 62% Medicaid. And Medicaid reimburses about 60% of Medicare rates for primary care. And that's just not sustainable for me. I know I'm not the only pediatrician facing this issue. In fact, another one of the partners in my practice has also closed their practice to new medication patients over age 5. Furthermore, many private practice pediatricians don't accept Medicaid at all. I fear that if Medicaid rates don't improve, this trend will continue, and that will negatively impact access to care, especially for vulnerable populations in urban and rural communities. We're requesting that the Kansas Legislature allocate $1.6 million to increase Medicaid rates for primary care pediatric services. Investing in pediatric care by closing the Medicare-Medicaid gap is necessary, fiscally responsible, and the right thing to do. Thank you for your time.
Thank you so much. Just a moment, folks. I want to make sure I highlight something here. Okay, moving on next, we have via WebEx, Dr. Mary Ann Lynch Small, Medicaid Projects Manager, Oral Health, Kansas. Dr. Lynch, are you on?
Hey, can you hear me?
Yes, we can. Welcome.
Great. Thank you, Chairman Bueller and the members of the committee. I'm Dr. Mary Ann Lynch Small, a dentist by training and the Medicaid Projects Manager at Oral Health Kansas. I want to start to describe a roadmap for our Medicaid dental program, including recommendations from the Special Committee on Sedation Dentistry. And you have my written testimony, so I'll summarize. Our oral health is central to our daily activities, but also critical for our overall health, with poor oral health linked to complex and really high-cost medical conditions like diabetes, adverse pregnancy outcomes, and increased need for emergency room visits. Our oral health is also linked to our ability to participate in the workforce, with a national loss of $45 billion in productivity due to oral health problems each year. The American Dental Association has economic models showing investing in the dental program and improving oral health will reduce costs in medical care spending in these high-cost areas. And also we find that extensive dental care is much more costly than preventive care. As a dentist, I know that you can only proactively manage dental disease if an individual can access dental services. Right now in Kansas, there's about 1,500 dentists, but only 30% of these dentists take Medicaid. So that's 460 dentists for 468,000 people. And the distribution also disproportionately impacts rural Kansans. There's 41 counties that have no Medicaid dental providers at all of which are rural. You've already heard how this affects people in Kansas, and you'll also hear from dental providers. But I wanted to outline the kind of to have a fruitful and economically sound Medicaid dental program, we have to address 4 interlinking challenges. The first is coverage of Medicaid dental services, and in great news, this has already been addressed thanks to the work of this committee, and we're really grateful for your support. The second is education of consumers and dental professionals, and Oral Health Kansas and our partners are committed to addressing this barrier, and this work is actually already funded by grants and underway. The final 2 challenges are administrative barriers to becoming a Medicaid provider and the Medicaid dental rates. And my colleague Tanya Dorf-Brunner will outline these challenges and also a proposed model to address these. So thank you for your time, and I'll stand for questions at the appropriate time.
Doctor, thank you so much for your testimony.
Thank you.
You're welcome. And with that, we will move to Tanya Dorf-Brunner, Oral Health Kansas. Tanya, welcome to committee.
Thank you. I want to be as fleet of feet as Aaron was there. And thanks so much for your time this afternoon. Again, my name is Tanya Dorf-Brunner. I'm the Executive Director at Oral Health Kansas. So as you heard from my colleague, there's been a lot of work has already happened around 2 of the big 4 problems in the Medicaid dental program. I want to talk about Missouri because Missouri created the model that addresses the other 2 parts. So in 2022, the Missouri Legislature did a rate increase on par with what we're talking about this year. Our sister organization in Missouri at that same time started what is called a dental Medicaid facilitator program to do outreach to dental offices and provide technical assistance to work on administrative barriers. In just 2 years, after those 2 things happened, in 2 years, the dental provider network in Missouri grew by 450. 80,000 more people received care, and the number of rural counties without a Medicaid provider went from 36 to 17 in just 2 years. But it was a combination of those two things. The investment in those rates went directly to people receiving care, and the combination was successful. So how are we getting started in Kansas? So at Oral Health Kansas, we actually are already beginning that dental Medicaid facilitator program. We have grant funding, and we are doing outreach to dental offices to help them with administrative hurdles, and we're especially going to be focusing on those 41 counties without a Medicaid provider. So that leaves just the final hurdle. Dentists tell us over and over that low rates are the biggest barrier to them becoming Medicaid providers. You've got a lot of statistics in my testimony. But essentially, dental offices are small businesses in our community, and they simply need a meaningful incentive to be able to provide care for Medicaid members. You'll see in my testimony there's a big chart with over 36 organizations and dental offices joining us and advocating for a rate increase. And as you've also heard, the Interim Committee on Sedation Dentistry recommended an overall dental rate increase after looking at the barriers last fall. So we are asking this committee to tackle this final barrier by including $16.9 million in the KDHE budget out of SGF, and with the federal match that comes with that, the total investment would be $44.3 million. The data and the experience shows that we can be successful with the combination of the Medicaid Facilitator Program and a rate increase, and we are ready to do this. Just real quick on the other two other things real fast. We're also asking the committee to follow the Interim Sedation Committee's recommendation to increase the rate for the code paid to hospitals for allowing their operating rooms to be used for dental care. That's the GO330 code. We're asking that rate to increase to the Medicare rate of $3,087. The cost for this increase is $1.3 million SGF, and again with the federal match that actually totals up to $3.4 million. And then finally, we also support the investment in the donated dental services program. It's been a dozen years since that program has had an increase, and it just simply costs more to operate that program after 12 years. So thank you for your time, and happy to stand for questions at the appropriate time.
Tanya, that was a lot. Thank you so much.
You're welcome.
Okay, next we have Tara Mays. I saw Tara somewhere. Vice President, State Legislative Relations, Kansas Hospital Association. Tara, welcome to committee.
Good afternoon, Mr. Chairman, members of the committee. I am Tara Mays. I appear before you on behalf of our 121 community hospitals across the state of Kansas that serve your constituents in your districts all over the state. I am very pleased to report to you all that some of those critical investments that you made last year have helped. As I stood before you last year, we had 73% of Kansas hospitals that began the year with a negative operating margin. I'm happy to report that number is down to 67%. So 67% of our hospitals began 2024 with a negative operating margin. So we're headed in the right direction, thanks to a lot of the investments that you all made last legislative session, including the Medicaid rate increases, which we have heard from our hospitals have been helpful, and we would hate to lose momentum on those Medicaid rate increases. You will see in my testimony a chart where we have gone through and compared our Medicaid rate increase, Medicaid rates, including the increases in Kansas, to those of our surrounding states. And you will see there is more work to be done. So we appear before you today to ask for the continued momentum in Medicaid rate increases in the state of Kansas. We also want to thank you, as Jennifer mentioned, for the investments in some of those really critically needed services. We hear from hospitals across the state that they cannot operate behavioral health beds and things like maternity care without significant losses. So those add-on payments that you really did help our hospitals be able to maintain behavioral health beds in the state of Kansas. We believe that expanding on that and allowing our geriatric psychiatry beds in the state of Kansas would be a great investment to continue those services across the state. The other thing I wanted to mention to you all today is our Rural Hospital Innovation Grant Program. This was actually a legislative proposal when you all passed the Rural Emergency Hospital legislation, and it allowed 15 of our hospitals across rural areas of the state to make investments. We only have 3 hospitals at this point that have transitioned to become a rural emergency hospital. That's Arc City, La Crosse, and Mound Ridge. There are going to be hospitals in the next few years that are going to continue to explore the rural emergency hospital model, and we would advocate that a Rural Hospital Innovation Grant Fund needs to be continued into the upcoming fiscal years ahead. The other thing I just wanted to mention to you all today is that the provider assessment assessment is something that is very critical for our hospitals, and I know Chairman Carpenter has done a lot of work on the provider assessment over the years, and you all added language into the budget last legislative session to allow our hospitals to increase to go up to 6% in our provider assessment. We will need that in permanent statute at some point, but we would like this committee to be the backstop if we need to put proviso language in to continue that. So wanted to mention that as well. The other thing that I wanted to mention with you all is we are seeing a significant increase of our hospitals having to board patients in what we call avoidable patient days. And what that really means is it's instances where patients remain in the hospital much longer than is medically necessary due to either delays in discharge, might be caused by lack of post-acute care placement, homelessness, transportation delays, waiting on insurance approvals. There's a lot of reasons for these, but our avoidable days we're seeing consistently increase. We surveyed our hospitals just before we came to this committee, and of the 18 hospitals that responded, they could identify 10,713 avoidable days. So avoidable days means the patient's sitting in the hospital, we are getting no payment for that patient. It equates to, just for those 17 hospitals, $8.5 million in uncompensated care given in the state of Kansas. So we would like to at some point explore with this committee the development of something that other states have done, which is creation of a patient avoidable days program. Also, one last thing I wanted to mention to you all, you heard from the agency yesterday about the need for a centralized credentialing system for our MCOs in the state of Kansas, and hospitals across the state tell us that the credentialing process that a provider has to go through is really driving up healthcare costs, and it requires them to spend a lot of time and effort. So a lot of states across the country, as we talk to our colleagues, many have already moved to a centralized credentialing system, and so we cannot emphasize to you all enough the importance of the centralized credentialing system to our hospitals. With that, Mr. Chairman, those are, I think, our major asks, but with that, I'm happy to stand for questions at the appropriate time as well, too.
Tara, thank you so much. Okay, folks, moving down, we have Sean Gatewood, Can Care Advocates Network. Sean? Welcome to committee.
Thank you, Mr. Chairman, members of the committee, for allowing me to testify today. I will refer you, just for the sake of your own time, to my written comments. We have a few issues that we address in there about HCBS rates. We want to join the comments you heard earlier by Oral Health Kansas and the Alzheimer's Association. But I want to talk a little more in depth about two specific issues. One is the protected income limit that you've heard about from a couple of folks. And so I guess the easiest way to explain that, it's a complicated issue sometimes for folks to understand. But how that essentially plays out, given there's a $475 limit per month for individuals to access care, it's essentially it's 100% tax on somebody's Social Security check over and above that amount that the provider is on the hook to try to collect. And so it's really, there's a bureaucratic nightmare, but it also is a disincentive from work and full recovery. So we want to join the comments of the others on increasing that, and also just point out the success that we had when we increased it for the HCBS waivers a couple of years ago. I think that anybody that was involved in that and still to this day have seen nothing but positive results from a state bureaucratic sense and a patient outcome sense. So I wanted to talk a little bit about that. And then we also want to be, is this kind of going in and out, or am I like moving too much? So we also want to be on the record. Our members unanimously support the expansion of the state's Medicaid program. We see this as a very simple way of increasing access to care for Kansans all over for those with limited means. So thank you very much, and I will answer questions at the appropriate time.
All right. Sean, thank you so much for your testimony. Okay, I know she's out there. April Holman, Alliance for a Healthy Kansas. April? Welcome to committee.
Thank you, Mr. Chairman and members of the committee. My name is April Holman with the Alliance for a Healthy Kansas. Among other things, the Alliance works with a coalition of about 135 different organizations across the state who have come together to work to expand eligibility for our Medicaid program in Kansas. So I wanted to just point out that in the governor's recommendations for her budget, she did include funding for Medicaid expansion, and we would ask that you would include that so that there would be time in the process for a substantive bill to be introduced, which I understand is imminent, and for that to get through the process before any decisions would be made about taking that funding out. So just to give you a little bit of an idea of some of the benefits that Kansas would have if we were to allow Medicaid expansion to proceed, we would be able to catch up with the 40 states, including all of our neighbors who have already done this. It would keep money in Kansans' pockets because when there is hospitalization and other care that cannot be paid for. There's uncompensated care, and we all end up picking up part of the tab for that. It would shield Kansans from medical debt. If you have coverage, you don't incur that debt in the first place. It will remove barriers to work because if people are physically and mentally healthy, then they are more able to be at work and stay at work. It will boost our economy with all of those federal dollars that come into the economy, and also it helps us to compete with our neighboring states who already have this benefit, and it helps to defend rural counties or rural communities from hospital closures and the negative fallout from that. There is a signing bonus that is still available for the remaining states who expand eligibility for their Medicaid programs. That is included in the governor's budget. Our signing bonus would be about $112.5 million in fiscal year 2026, and that would offset the state's cost. We also know that there is a lot of talk about federal cuts to the Medicaid program, and one of those things is block grants. So if we were to have a block grant with the current status quo in place, it would basically freeze Kansas at a disadvantage to all of our neighboring states. So with that, I would respectfully ask you to retain funding for Medicaid expansion in the budget. Thank you.
April, thank you so much. Okay, moving down next, we have Janet Williams, the CEO of Minds Matter. Janet, welcome.
Not been before this committee for a really long time, and I will keep it quick. I'll be back on Thursday as well. How are you? I am here today to talk about network adequacy, access to choice, and some of the competing priorities that providers are up against. For the past 33 years, I've worked with people with brain injuries in Kansas. Some of you know that already. And the state approached us because there were over 800 open hours for therapy for people on the brain injury waiver. All counties were not covered, and there weren't enough providers. So we were brought together with the MCOs. Because the rate is so low on the brain injury waiver, we were forced to negotiate rates with each of the 3 MCOs. We did that. The procurement happened. The 3 MCOs became the current MCOs. We were able to decrease that 800 hours down to under 300. Our turnover went from 20% down to 2%. And we were able to hire 18 therapists, and we helped 124 people move out of institutions. The cost per day of an institution for someone with a brain injury is $1,400 a day. It is $99 a day for someone on the brain injury waiver. So you can do the math and understand all of that. To our shock and dismay, on December 3rd, we received notification from Sunflower State Health Plan that they were decreasing our rate by 20%. We have 154 people with Sunflower State Health Plan, and we were only given 56 days notice. So our expansion into 105 counties, our hiring of 14 therapists, and all of that is now moot. Of 1,000 people on this waiver, we work with 543 of them. We are the largest provider. We're the only one who provides all of the services, and we're the only one in all of the counties. We don't know why this happened. We were told they need to save money. And so on February 1st, our rate will go back 20%. I don't know about any of you. I do not operate with a 20% margin, certainly not on Medicaid rates. I have a budget that is 1 year at a time. Our budget was set. We are grateful that it is now open enrollment. We have been forced to contact all 124 people with brain injuries who are in the middle of a rehabilitation program with us to let them know that they have until April 1st to switch to one of the other 2 insurance companies or stay with Sunflower. When KDADS asked Sunflower if they have providers, they said, we're going to wait until April 1st to see how many people are left. We think a vast majority of them will follow Janet and Minds Matter. And so a planned disruption in managed care, I just think is unconscionable. I've been doing this for 33 years. I am very concerned that Healthy Blue and United Healthcare could do the same thing. The rate for the service we have in Kansas is $18.99 per unit. Missouri, it is $30 per unit. Nationwide, the average is $35 per unit. And this is the first time anyone here has ever heard me ask for a rate increase. I am always in front of you saying we need no waiting list on the brain injury waiver because I think everybody deserves these services. And I am here to say, bring on the waiting list so my therapist can remain employed and so that people with brain injuries can continue to get their therapy. And that is my testimony today. And I also ask that you put extra measures in to make sure that these waivers aren't running with a hidden waiting list, that there is network adequacy. We're the only ones in 105 counties. That's not easy to do. Our therapists, physical, occupational, and speech therapists, every one of them has either a master's degree or doctorate. It's not easy to find people. KU, we're competing with KU. We have more therapists than KU. We have 154 therapists right now. And so that's what I would like to bring before you today. So thank you very much.
Thank you very much for your testimony. Okay, we're getting close. I have David Weinberg from Leva Nova. David, welcome.
Thank you, Mr. Chairman and members of the Social Services Committee. My name is Dave Weinberg, and I am a Senior Manager of Government Affairs and Market Access for LivaNova. That is the company. This is the company that manufactures the vagus nerve stimulation or VNS therapy for drug-resistant epilepsy patients. Here's a little show and tell for you. Those are the 2 components that are implanted in the patients. And these patients are drug-resistant epilepsy patients, also known as DRE. I'm here to advocate for drug-resistant epilepsy patients and their prescribing neurologists because they are desperately in need for better and more improved surgical access to VNS implants. I recognize that the state's priority right now during the session is to identify ways to reduce funding in all agencies. That said, a VNS therapy can harvest significant cost savings for the state if they're willing to invest a small amount of money to improve the Medicaid reimbursement for VNS surgical implants to hospitals. So that said, we respectfully request an SGF increase of $420,000. A health economic study from Emory University revealed that the device pays for itself in a year and a half because of because of the efficacy of the therapy and reduced healthcare utilization costs. A 4-year study by Kaiser showed a 99% reduction in ER visits in their VNS patients. A 5-year VNS budget impact model that accounts for all healthcare utilization costs could yield $4.7 million in cost savings for Kansas based on the annual implant average of Medicaid patients in the state, which is only 58 a year. DRE patients comprise 1/3 of all diagnosed epilepsy patients. They are the worst of the worst. The types of seizures, frequency, and the violence of the seizures cause damage to the brain. And significant seizure-related injuries require hospitalizations, resulting in tremendous cost to Medicaid. How much is tremendous? South Carolina Medicaid ran their own one-year data on their DRE members in 2017, and they discovered that they paid out $870 million for this small patient population. Kansas ranks in the bottom 10 in state Medicaid reimbursement across the country for VNS rates. 2009 was the last rate increase for hospitals. The impact of these low rates have left only 5 remaining hospitals in the state offering the surgical procedure for this desperate and suffering patient population. Most of those 5 are reevaluating whether they'll continue to offer this procedure this year. So thank you for your consideration to approve an SGF increase of $420,000. This increase would open the door for better access to care for all DRE Kansans and provide adequate reimbursement for hospitals. I appreciate your time, your interest, and I can stand for questions at an appropriate time.
Dave, thank you so much for your testimony. Okay, next I have Janelle Shoemaker, Hero Practice Services. Janelle, welcome to the committee.
Thank you. And good afternoon, committee members. Thank you for the opportunity to speak today. My name is Janelle Shoemaker, representing Adventure Dental and Vision. We are a group of children's practices with a mission to serve the most underserved population, including Kansas's children on Medicaid. I'm here to highlight the critical need for investment in our state's Medicaid program to ensure that all children, regardless of their socioeconomic status, have access to high-quality dental care. Kansas's pediatric Medicaid reimbursement rates have remained stagnant for years, failing to keep pace with the rising costs of providing care. Over the past 4 years, we have incurred rising costs on dental supplies, materials, lab fees, staff wages, rent, and insurance premiums. We all know the importance of pediatric dental care and its impact on a child's overall health. Untreated dental conditions can lead to a difficulty eating, speaking, and can impact a child's ability to concentrate in school. The American Academy of Pediatric Dentistry recommends that children receive their first dental visit by age 1, yet 80% of dentists cite low Medicaid fees as their top barrier for providing care to these patients. As others here today have mentioned, in 2022, the state of Missouri increased their Medicaid fees near to what commercial payers pay. And the following year, Medicaid members, over 50,000 people received care in addition. Increasing reimbursement rates to align with regional and national benchmarks will encourage more Kansas dentists to participate in the program. Having more providers in the network will increase preventative services that will help keep children out of the ER, therefore saving the state money and on unnecessary hospital bills. Increasing pediatric reimbursement rates is not just a policy decision, it is a necessary investment on the health and future of Kansas's children. I respectfully urge the committee to prioritize a rate review of pediatric dental Medicaid fees. Thank you for your time and consideration, and I'm happy to answer any questions.
Janelle, thank you so much for your testimony. Okay, next, I think we have via WebEx, Dr. Nick Rogers, dentist. Dr. Rogers, are you on? Doesn't appear that Dr. Rogers is still with us. The last conferee I have is Megan Skaggs from Project Access. As you approach the microphone, thank you for your patience getting through the 31 others that were in front of you.
Well, thank you, committee, for your time today.
You're very welcome.
There you go. Solid, I'm done. No, thank you very much for your time this evening. I represent Project Access in Wichita, Health Access in Topeka, and YJO Cares in Wyandotte County and Johnson County. We coordinate donated health care for low-income, uninsured residents of Kansas. These programs fill a unique gap, offering specialty care such as treatment for cancer, heart disease, or joint replacement that safety net clinics and emergency rooms cannot provide. We have a network of over 2,000 local physicians, hospitals, and medical providers that donate their services. This includes limited dental and mental health care, prescription assistance, and durable medical equipment. This collaboration helps residents remain employed, support their families, pay taxes, and avoid medical debt or bankruptcy while reducing emergency room reliance and public assistance. Specialty care often requires a comprehensive coordination, such as when an oncologist is willing to donate his or her time. That often is going to supplemented by hospitals, surgery, resources, anesthesiologist, nursing staff, etc. All of these are arranged through donated care for our programs for these low-income uninsured residents. Since our beginnings, our partnerships have served over 55,000 residents of Kansas, and we have provided over $671 million in donated health care and almost $16 million in donated prescriptions and medical equipment. This is an extraordinary testament to the generosity of the medical community in Kansas. Patients must meet income guidelines, and they must lack insurance, Medicare, Medicaid, Medicaid, et cetera. Most patients in our programs work low-paying jobs and cannot afford coverage. We have support from our local government foundations, United Way, and individuals that help cover our funding. This yields a $15 return in investment for every $1 in support. We are hoping that the committee will consider our request for $550,000 in the KDHE budget to help us sustain these critical services. This investment would strengthen our programs, enabling continued life-saving care for the working uninsured. And by supporting this request, the state would ensure that in their time of need, working Kansas can rely on these vital programs and the generosity of medical providers.
Thank you for your testimony.
Thank you very much.
Committee, that is the last of the in-person conferees. We have run over. However, we still have many of the conferees in the audience. So I want to make an opportunity available for anyone who might have a question of a particular conferee at this time. Seeing none. Representative Steens?
Thank you, Mr. Chair. Sorry, I have a few. I had one for, and I apologize, you may have said this, I think it was for Scott Lopez. Is that you? No. Oh, did he leave? Okay. Something about with the wheelchairs. The gentleman that spoke about, did he leave? Oh, I'm sorry, I missed him, I apologize. I just had a question. Is there anyone here still from that, any of the wheelchair companies?
Pat Jonas.
Was this was about the prior authorization and the repairs? Okay. Then, sorry, I apologize. I did not see him leave. And then I had a question for Janet. Janet Williams from Mines Manor.
Janet?
Thank you, Janet. And thank you, everybody, for your presentations. I can tell how passionate you are about all the people that you care for. So, Janet, I had a quick question. You said that your reimbursement right now is $18.99 a unit. Is that correct?
That is the Medicaid reimbursement.
Medicaid, okay.
I have negotiated special rates with each of the MCOs because you can't hire a physical therapist at that rate, or occupational therapist, or speech therapist.
Right.
And that also includes drive time, mileage, benefits, training, CEUs.
Okay, yeah, that's pretty low.
Yeah.
And so is that 20% cut that you were saying, so it's on
It's of my negotiated rate.
Okay.
Yes.
Thank you. I
Yes.
just wanted to clarify that.
Yes.
Representative Rivas?
Jennifer Gehring come back up? Via Christie. Yeah, thank you. So my question is, there's a lot of numbers here and a lot of different asks. So I was looking at, like, one thing is an increase at 5 million, but then there's also the fact you're going to add more beds at a lower rate, so you're probably going to lose more money. I mean, so trying to sort all these numbers out and where we're headed. So, and if you need to get back with us, it's okay. Like, what is the real ask this year, and will that really cover what your losses are? And then what do you project is going to happen in the next 2 or 3 years with the additional beds if you're getting reimbursed at a rate that doesn't cover expenses?
Certainly the ask is not covering the loss completely. Mental health crisis is just going to continue to get worse. So to say what that will be in the future, I'm not sure, but I just know it will continue to go up. With our increase of beds, that actually is not saying we're going to be able to see more people. It's just meeting the need we already have. So basically, we have been overflowing for a number of years, and happen to put a lot of these patients within our halls. And again, increasing the beds are allowing each and every patient to have a room to be able to start their recovery, which is specifically very important for mental health patients, because that extra stimulus sometimes can further exacerbate their condition that they have going on at that time. So yes, the 15 million supplemental is certainly not looking into increase to sustain our losses, but again, also looking at other and all surrounding hospitals within the state of Kansas to help just keep open the beds that they currently have, because we can't afford to lose any of them at this point in time. Because I'll be honest, I have a waiting list daily of people trying to get into the hospital, and so I can't meet that need as it is. So if we further close beds, that list will just continue to increase. So.
Thank you. Representative Ballard, did you have a question, one of the conferees?
Thank you. I would like to speak with Dr. Tasha Van, please.
Dr. Van, welcome back.
Thank you very much. And then I just have a quick follow-up with Janet Williams. But you looked here when you say you take 5+.
I'm not taking 5 in. No, yes, now I'm taking under 5 new patients only.
Can you tell me, you took older,
I took all.
You took all.
Yeah.
Where do those individuals go now, since there's so few doing Medicaid?
I don't know. Some of my partners are still taking all. So for some of my partners who don't have full panels, they are accepting new patients over 5. But yeah, I'm not sure.
If you were, would you have a waiting, if you were taking, would you have a waiting list?
Probably not. So I'm the newest partner in my practice. I've been there since 2020, but I have availability. So I'm not, some of our more established partners, they're booking out a couple weeks. Most people can get in to see me within 72 hours.
Thank you very much.
Sure.
And Janet Williams?
Representative, can we keep her at the mic?
Oh, sir, that's, sorry, I should have done that with her, yeah.
Doctor, we have a question from Representative Oropeza, and then maybe one from Representative Reese. So 1, 2.
Yeah.
So please don't go anywhere.
Thank you, Mr. Chair. So my question is, say we were able to figure out a way to increase the Medicaid rates for children's, for pediatrics in general, do you find that within your group there would be a pledge to open up the over 5, at least in your practice, if the rates were to change?
I'm pretty sure. I mean, our practice for the most part has always been open, but the past couple years have been a little bit rough. And so looking at the numbers, you know, it ranges. Some of our partners are at 39% Medicaid, some are at 50%. I'm the only one at 62%, so that was part of the reason I just needed to close for a little bit, because I can't see more patients than I'm already seeing, and still cover my overhead.
Thank you. Thank you, Mr. Chair.
Representative Reese.
Thank you, Doctor. Last year, or last session, we increased the rates for pediatrics. Did that help?
I don't know. I didn't feel it, so I'm not sure if hospitalists or specialists felt it more. I did not feel it. From the time I started till now, when I started to make a base salary, I was quoted 14 patients a day was what I needed to see on average. Right now, to make that same amount, it is 18 patients a day. I barely take vacations because I'm self-employed. So if I don't see patients, I don't make money. So being here today means I lost a whole day of revenue. So if that increase helped, it did not help. I didn't feel it. I'm not sure.
We had a question of the person that came to ask for the rate increase about, could they also make a pledge to accept more Medicaid patients? And that person could not.
I can. I mean, our practice can. I think it's part of our mission and part of our heart to be able to accept all insurances. And only 2 of us right now are not accepting new patients over 5. Everyone else is. And I hope that it's temporary. I'm hoping that by 2026, my numbers will be a little bit more even, and then I can open back up.
Thank you.
Doctor, thank you so much. I think we're switching conferees. Janet?
I should have jumped on the other one too. I'm sorry. I appreciate very much your answering our question as well. And for Janet, when you said sunflower, was there any notice that you get, any warning that they weren't going to provide these services?
No. On December 3rd, we were contacted that they needed to lower our rate. We met with them. They said, this is how much we need to lower it. We're lowering it February 1st. We asked for a value-based contract. We asked for, are there other things we can get reimbursed for? And we asked for an extension till April 1st. And they came back and said, the only way we can extend till April 1st is if you accept this 20% decrease. And I really was left no alternative. I did submit a letter of termination because, I needed to give 6 months notice. So now we'll go April to July with the lower rate.
So you have 443, you provide that
Right.
many. But the one I'm really concerned about is the 124 brain injury, because that was the one that we worked really hard in order to make that eligibility in many ways. And I think, as you know, I've been on this committee for a long time. And so when I see where brain injury is being affected.
So we have 500 with brain injuries, 124 are with sunflower.
Now, did they give you an explanation as to why they made that move?
They said our rate was too high. But it's only been a year.
Thank you, Mr. Chair.
Okay, with that, committee, barring any additional questions, I would like to say this. We do have a means to contact every one of the conferees today, so if you do have individual questions for someone who provided testimony today, we have a means to contact them. I don't want Francie to get upset with me, but she has their contact information. I say that lightly. So first off, thank you to all the people who provided testimony and those in the audience. This was a long day, but it's very, very valuable and will be used as we move into the next phase of this in terms of recommendations. I do want to thank Francie and the research and revisor staff who sat there to this today. We've got a lot of work to do based on the information that was presented. So with that, we'll adjourn the meeting today, and thank you for your time and attention.